Everyone, good afternoon. Welcome to the first session of Academic Hour, continuing Professional Development Lecture Series organized by the Clinical Society, Base Hospital Mahiyanganaya, together with the Branch Union of Government Medical Officers Association. An ancient Sanskrit sloka said, Nabase Bhushanam Chando, Nari Bhushanam Pati, Pruthuvi Bhushanam Raja, Vidya Sarvasya Bhushanam. Moon is the jewel of night sky. Husband is the jewel of a young lady. King is the jewel of his land. But the knowledge and wisdom will be the jewel of all human beings all the time. My dear friends, it is indeed a great pleasure and a great achievement that we initiated Academic Hour continuing Professional Development Lecture Series. First of all, let me warmly welcome the Director, consultants, medical officers, relief house officers, and house officers for the today's event. To mark the inauguration, I would like to cordially invite the following dignitaries to light the traditional oil lamp. Dr. M.S. Bandara, Director, Base Hospital Mahiyanganaya, Dr. Rohitha Amara Witharana, Consultant Physician and the President of the Clinical Society, Dr. Salinda Marasinghe, representing the Clinical Society, and Dr. Sajith Bandara, representing the Branch Union, and a representative from the peripheral units to light the traditional oil lamp. Thank you. Thank you. Before we move on to the first lecture of the series, let me outline our plans to 2024. We will be having 2 lectures per month, which will fall on the first Wednesday and on third Thursday. Once in 3 months, we hope to meet outside the hospital for a lecture followed by a fellowship dinner. Hope all of you will join us throughout the year. Today, we look into a very important topic, snakebite envenoming, neglected tropical disease at rural Sri Lanka. I cordially invite Dr. Prabhash Hathurusinghe, our new consultant physician, to introduce the presenter.
Right. Good morning and welcome you all for the inaugural academic session of Base Hospital Mahiyanganaya. In my opinion, I just started working here about a couple of weeks ago, and I personally believe this is a very good move for the junior doctors and the consultants. It will continue as we schedule. So today, introduce our presenter, Dr. Rohitha Amara Witharana, my colleague. Bit about Dr. Rohitha. He's graduated from University of Peradeniya and got postgraduate qualification MD Medicine on PGIM Colombo. He worked as a board certified consultant since 2007, worked in several hospitals including Kahavatta, Hangalla, Deniyaya, Mahiyanganaya, National referral and also the teaching hospital session. And I would like to tell about something regarding probably we might not know. He worked as a lieutenant colonel in Army Hospital in 2017 and worked in United Nations hospitals in South Sudan for about 2 years since 2017. That's a very good exposure and very good experience. Uh, and also, he's a very academic and clinical fellow, has done more than 20 abstract with local and international publications. He got awarded for best presentator and poster presentator for Young Physician Forum in Ceylon College of Physicians. He was a former secretary in Sri Lankan College of Internal Medicine in 2020 and currently council member of Sri Lankan College of Physicians. So we were very glad to have him in base hospital Mahiyanganaya and like to share his experience regarding snake bite, poisoning and toxicology where the areas of his interest. So I would like to cordially invite Dr. Rohitha to deliver his speech.
Afternoon, everybody. Thank you, Dr. Prakash, for kind words of introduction. And first, I would like to thank the director, the president of the GMOA branch, Mahiyanganaya Hospital, for inviting us to arrange and organize this continuous medical education program for medical officers who are working in this hospital and hospitals nearby Mahiyanganaya. Let me to start my presentation today on snakebite envenoming, a neglected tropical disease in rural Sri Lanka. Is it clear? Can you hear me? Objectives of today's presentation is snakebite envenoming. I will discuss few case scenarios and few studies which we have done on snake envenoming to emphasize the gravity of snake bite at periphery. Then I will go for clinical importance of clinically important snakes and snake identification, clinical evaluation of snake bite envenoming, management and prevention. Few case scenarios. Then come for the first study which we have done at Deniyaya on Sri Lankan green pit viper bite, a clinico-epidemiological study. Then hump nose pit viper envenoming, again epidemiological and clinical features from a prospective observation study. And this is ongoing study in our wards, epidemiology and clinical features of snake envenoming in Mahiyanganaya, Sri Lanka. So this is the first case of severe envenoming after Russell's viper bite. Our patient was 39-year-old lady who was bitten by a snake while collecting vegetable and admitted to the Wales Hospital, Mahiyanganaya. She was collapsed at the ETU and with much difficulty we resuscitated the patient. This is actually 1 hour after the incident, patient collapsed. With severe circulatory failure, neurotoxicity and coagulopathy, patient was admitted to ICU. However, the patient died after few hours despite maximum medical care. After 4 hours, patient died. This is the offending snake brought by relatives. I think it is very easy to identify it by you all. You can see triangular head, the short tail, an inverted V mark on the head, and there are 3 rows of rings on the body. So it is very simply, you can all can identify this is a rhesus viper. And this is the same specimen. You can see this abdomen is abnormally distended. So you all know, if snake catch the prey, and just after catching and swallowing prey, there is no venom in the venom gland. So just after bite, that could be dry bite, and patients sometimes not get envenoming. But this patient was severely envenomated, so we have to think why this patient becomes severely envenomated. So abdomen is distended, probably there may be prey or swallowed something in the abdomen, or maybe eggs, or maybe abnormal disease or something can cause distension of the abdomen. So we dissection, and we take this partially digested mouse out from the abdomen. So it's very clear this is snake bite, and there was a very partially digested mouse in the abdomen. So, probably this snake taken large meal few days ago, and it was resting somewhere there in the land and garden, and our innocent lady step on the snake and get envenomation after bite. Right? So first I would like to thank Dr. Chintaka. He is one of my house officer. He has taken all photographs, and the dissection also done by himself, and all credits go to Dr. Chintaka. Then we, because of patients died in 4 hours time, we did postmortem, and Dr. Taranga is here, our consultant GMOA. He helped a lot to study this case, and this photos given by Dr. Taranga, and you can see bleeding from the puncture site and ecchymosis all over the body. These are the autopsy findings. The dissection of the bite site, there is bleeding, and most of the internal organs were normal except heart. There are small bleeding patches in subendocardial region. And also this histological study done by our consultant JMO, and he gave all pictures for this presentation, and you can see few hemorrhages, subendocardial hemorrhages, and kidney is totally normal, and there is massive accumulation of neutrophils in the lung. So those are the pathological findings we have seen, and again I would like to thank Dr. Taranga, our consultant JMO, giving these very valuable photos for this presentation and for this case report. So what can we learn from this case report? So this case, I start my lecture, snake envenoming is a neglected tropical disease in rural Sri Lanka. WHO announced since 2017, snake bite is a neglected tropical disease in the developed countries. So you can see this innocent poor lady is mostly affected by the affected communities, poor social economic, living with poverty, and they have lack of medical knowledge on snake bite. So she went to garden to collect vegetable to prepare their lunch, and accidentally her target is collecting of vegetables, and she never think about the dangerous things surrounding, and she stepped on this snake and she got bite, and she died in 4 hours time. A lot of things we have to learn this case because of the medical education among our community sometimes can prevent this sort of death, right? Because other thing is poverty and current crisis in the country also totally affect and increase the number of death in our This is the second case, a venomous snake bite, but no envenoming signs. Our patient was 15-year-old boy from Diula Palasa, was bitten by a crate at 7:45 in the night while he was sitting on a chair. The patient was admitted to our hospital without any symptoms. That was a dry bite. We observed patient for 48 hours and discharged because she didn't get any envenoming signs, even no local or systemic envenomation. This is a snake brought by relatives, and it is very clear. You all can identify. Double rings are there, and vertebrals are. Can you take it out? Yeah. Double rings are there, and vertebrals are enlarged. And also, you can see subcaudals are uniserial, not divided. This is a dry bite even after venomous snake bite. This is possible. So, what is the learning point here? You know, patients come to you with venomous snake bite, but there is no envenoming signs. Are you going to treat for this patient? No, because antivenom is very dangerous, sometimes even can kill the patient with anaphylaxis. Right? So we have to carefully start antivenom. If really needed, only we have to start antivenom. So before in 1980s, you know, Sri Lanka is a country where prevalence of bite is highest sometimes, right? So reason you know, because most of the patients go to the traditional medicine and treatment given by these traditional physicians, and they do something, they did something, and sometimes patient died. So this is for an example. If this patient going to traditional medicine, the Mahatya will treat for this patient, and because the snake also available, then they know he cured this particular person. This message spread all over the village, and then the people go again to this traditional person and go for the treatment. Then can other patients can die. So what you can learn here. So all patients anyway we have to admit, and traditional medicine I will discuss. We have to stop, otherwise patient will die with traditional. So this is the third case, severe anaphylaxis after AVS treatment. Our patient was 28-year-old gentleman having bronchial asthma, presented to base hospital Mahiyanganaya after snake bite of his right leg. He developed severe neurotoxicity, coagulopathy, and incoagulable blood. 20 WBCT was more than 20 minutes. Severe local inflammation also. So if you see this patient, you know neurotoxicity, vascular toxicity, and with the local envenoming. So this is a case of process viper bite, right? So no, we can't wait. If you detect systemic envenomation after process viper bite, you have to start antivenom. So his antivenom was started. He developed severe anaphylaxis just after antivenom infusion with IM adrenaline, pyriton, hydrocortisone, and IV fluids, and also salbutamol nebulization. He recovered fully, but we can't wait. We have to restart antivenom. So immediately we restart antivenom. Patient repeatedly develops severe anaphylaxis, low blood pressure, dyspnea, and it's a very difficult case to manage early in the morning. Around, I think, 2 o'clock, we went to the ward. Then it's a very difficult case to manage. So no options. What we can do for this patient? At that time, ICU bed also not available for the monitoring. So it's a very difficult case to manage. So I discussed with several experts on the management about management of this particular patient. So finally, the option is we decide to give little high dose of hydrocortisone and observe patient for 6 hours. The reason is if you give hydrocortisone, hydrocortisone is not drug for the anaphylaxis management. If you give hydrocortisone, after 6 hours time we start antivenom. There was no any problem with anaphylaxis, no allergic reactions. So we comfortably we use antivenom and treated for patient Then also we repeated another dose of antivenom also because the patient's 20 WBC was very high. So repeatedly we give antivenom and without any complications. So what are the things you can learn here, right? This case, if you are working in periphery, I'm sure you can give antivenom and treat the patient, but you have to be careful and prevent this way. Patient die because of not the envenoming, that is due to because of anaphylaxis. So that is the most. This is a fourth case, last case scenario I am going to discuss here. Myoclonic epilepsy after common grade 1. So our patient was 21-year-old gentleman presented to our hospital after common grade bite, and he developed severe envenoming signs of ptosis, double vision, and respiratory distress despite antivenom therapy. Patient was admitted to ICU, and later he developed myoclonic and GTC convulsions. ECG confirmed the diagnosis, CT, MRI, and all other investigations otherwise normal. So this is a case of myoclonic epilepsy after common grade bite, and patient responding well for the treatment. We started clonazepam and levetiracetam. So you can see this small video here. Can you all hear from the website? Yeah. Okay. So you can see that video. This is small jerk. There are jerky movements. So this is the snake brought by relatives, and you can see this snake is again common crate with the double rings are there, enlarged vertebrals, and identification is not difficult. Right. So again, this credit for the photos of Dr. Rohan, one of our house officer. Now he is and so this is a rare case. If you review medical literature, this is one of the rare case after common grade bite. Right? So we are planning to publish this case in a medical journal. Already, Dr. Rohan already wrote this case, and we are planning to submit for the international medical journal. This is I will discuss very briefly few studies of on snake bites which we have done. The first study is Sri Lankan green pit viper bite in Denia when I was consultant there. It's a clinico-epidemiology study, and I briefly discussed this study. I'm not going in detail of objectives, then study design, and then methodology and results. I'm not going to discuss. So I briefly discuss something relevant facts. So we studied 24 green pit viper bite victims. This is the largest study up to now published because green pit viper in Sri Lanka is endemic to Sri Lanka. So there are no studies, only one previous study also they are done by Dr. Ratnayaka. So this is one of the largest study because this snake is endemic to Sri Lanka. And all cases were daytime bites despite green pit viper being a nocturnally active snake. And 16 patients were bitten while they were working at tea plantation. You can see large number of bites occurred while they were working in tea plantation. Commonest bite site was hand. Very important, right? More than 42% was bite site was hand. Then these are the photos of offending snakes, green pit viper. You can identify this, and this is a photograph of our patient who developed severe extensive limb swelling, and this is a photo of another patient with hemorrhagic blisters. up to species level. We identified all species up to snakes up to species level. So we identified Hypnalis hara were reported in Denia area, and Hypnalis nipa was not reported in that particular region. So most cases were associated with daytime activities. Bites can occur throughout the year. Extensive limb swelling, hemorrhagic blisters, and vascular toxicity were well recognized after envenoming by both species, Hypnali and Hypnalis hara. And there were no fatality or nephrotoxicity. So these are the specimens brought by our patients. You can see on the left a live specimen in a plastic bottle, glass bottle, that's hump nose. And the second, in the middle, you can see another dead specimen of hump nose viper. And the third, on the right, is a picture from a patient with hemorrhagic blisters. So again, this paper we publish in Toxicon Journal as a hump nose pit viper envenoming in Denia, Sri Lanka, epidemiological and clinical features from a prospective observation study. So this is the study ongoing in our wards, Ward 3 and Ward 4 now. Epidemiology and clinical features of snake envenoming in Mahiyanganaya, Sri Lanka. We started this study from 20th December last year, and up to now, around 50 cases were collected, and we are collecting data from patients. And these are preliminary data, and we have not fully analyzed the data. You can see this lot of patients come with a different species of snake bite. So the picture shows a large shield-tailed snake. That snake is non-poisonous one and it's wrapped around the finger, and patient came to the hospital because of the pink bite. So it's not a bite, and there was no envenoming signs. And this case I discussed, why this patient died. And you can see this is trinket snake or katak halwa. And this is hump nose viper. And you can see wolf snake's picture also. So these are the pictures from patients. First picture shows extensive limb swelling. And second picture is
that is crest. So again you can see subcaudals, if it is divided either poisonous or non-poisonous, but subcaudals are not divided, so basically it could be poisonous snake. We'll discuss later. So if you see L'Oreal's pit between nose and eyes, that could be pit viper. We have two groups, hump nose viper and green pit viper. So that helpful for the identification of the pit viper. So triangular head, you can see L'Oreal pit present, that is pit viper. If it is not present, that could be highly venomous or feebly venomous snake. Pit vipers, we have two groups, hump nose viper. If you see the head, you can see large scales on the head, shield shaped scales, and we have three species, Hypnale sara, Hypnale nepa and Hypnale hypnale. I am not going to discuss more detail. The morphology of the hump and scale distribution help to differentiate different species. It is difficult, but if you identify up to this level, it is okay for the management. So brown color, head covered with large scale, it looks like shield, and hump at the tip of the snout, that is hump nose viper. Then green pit viper, again L'Oreal's pit is there, and you can see this blackish corrugated appearance on the body and small scale on the head. So that is also venomous snake. Identification is not difficult. So this is green pit viper. And what is this? Anybody can guess? Can't. So anyway, this is, you can see like hump nose viper, brown color, small patches are there on the body. But if you see carefully, the hump nose is not there. So this is some other species, not hump nose, no L'Oreal hit pit. So this is Marpilla or cat snake. This looks like some the hump nose, but hump nose is not there. This is a very long snake. There are 3-4 species in this country. You know the Naga Marpilla, Le Marpilla, different names used. So depending on the species, so identification is not difficult. This brown color patches are there with dark patches and elongated and long snakes. So it is not difficult because hump is not there. This is called Marpilla or the cat snake, right? So what is this? It's very clear, triangular head. So this is a viper. The characteristic feature is, you can see on the head the bird's foot mark. So if you see bird foot mark on the head, this snake is saw scale viper, one of a highly venomous snake, reported case mostly from the Jaffna Peninsula, right? So then this is very simple. You all know what is this snake. We already discussed, short tail, triangular head, inverted V on the head with the 3 rows of rings on the body. So this is rhesus viper, highly venomous snake in this country. And if you see oval shaped head, so you have to identify cobra. You know this is not difficult. There is hood and with the spectacle mark, and there are 2 dots, black dots ventral. So the subcaudals are divided here. So the identification is, I think, not problem for you all, and highly venomous. If you see this enlarged vertebrates, again I discussed crate, we have 2 species, and if you see double ring on the body, so this is common crate or Indian crate, highly venomous snake. And this is Sri Lankan crate. You can see enlarged vertebrates and the single rings on the body, so not difficult to identify. Vertebral is the most important thing for identification of the crate. No other species with enlarged vertebrals. So this is I want to discuss here. The Sri Lankan keelback or blossom crate, this recently considered as venomous snake after publication in 2015, and this snake a victim developed severe coagulopathy after this bite, and he was admitted, and 20 WBCT also prolonged with bleeding, and anyway he recovered with supportive treatment. So actually victim was a photographer. When he handling this live snake, and he got this incident, and patient admitted with prolonged bleeding and the prolonged WBCT, and with the supportive treatment, FFP and everything, then patient recover. So after that we consider this is a venomous snake in Sri Lanka. Right. So non-venomous snake, it is very simply, you know what is this. You can see quadrant on the body, so that is python, and if sometimes a small python, sometimes difficult to differentiate from the rhesus viper. But if you carefully see these rings are quadrant shape. But if you see rhesus viper, the ring, that is the rows of rings are there, elliptical shape. So that is the difference. And this is, you have seen, this is the rat snake, and very elongated and having large eyes, and good swimmers and climb trees, and also fast moving, no poisons, you want run and catch prey. And this is very green color one, luminant green color one, no corrugated appearance, blackish color, and this is Ahatulla and green wine snake. And this is Aharakukka, I don't know, different name used in different places. So you can see these stripes on the tail and the body of the snake, and that is buff stripe keelback. I think you have seen Aharakukka is the snake, and a lot of patients come because killing this snake, these are non-poisonous one, right? And then this is very simple, anybody can identify, very beautiful snake. And this is flying snake of Polmal caravella. We have 2 species in this country. And this is also very common snake reported in Mahiyanganaya. A lot of patients, up to now we have collected I think 4 specimens, and patients kill this snake can come to the hospital. So this is trinket snake. You see the snake, there are 2 black lines, and this color, and the tail there is a brown color stripe on the top of the body and tail. So this is called trinket snake, and the single name is Katakalua, because if you see the open mouth, that is black color. So single term is Katakalua. And this is Haldanda or something, and the brown common brown bronze back tree snake. It is greenish brown color. It's a bronze color snake, very long one, tree snake. I think you all have seen. And this is one of the common snake considered as krait. So this is not a krait, this is a wolf snake. So you can see white ring on the body, and if you see carefully, vertebrae are not enlarged, so this is wolf snake and not difficult to identify. So this is another species, variety of wolf snake. So that is another species. You can see this white bands divide laterally. Clearly you can see dividing into 2, and also if you go to the tail end, so this the bands disappear, you can see sometimes dots. So that is a feature of this non-poisonous snake. Vertebrals are not enlarged. So then this is Depatnaya or pipe snake. It is very, if you know this snake, not difficult to identify. Brown and black color spots, very regularly distributed, ventrally, and white and black color dorsum. So not difficult. And this is water snake, keelback water snake. You all have seen this. And this is Lehmadilla. It's one of the red color one, brownish red color. Boy's rough seed non-poisonous snake. And another non-poisonous one, cook snake. And let me to talk few words about snake in Sri Lanka, Africa, because I worked there for 2 years, and very poor, one of the poorest country of the world. And that UN hospital I work there, mostly we look after and treat for the UN staff only, but sometimes the another peoples living in the surrounding area come with snake bite, very rarely, but we have seen number of patients snake bite there. So this snake is one of the world's most dangerous snake called mamba, that is reported in mostly in Western African countries, including South Sudan. And if even one bite and can kill patient in 30 minutes sometimes. Large amount of venom and very toxic substance are there. And this is puff adder. We have seen patients coming with this puff adder, common one, and even a lot of patients lost their legs after puff adder bite in Africa. And different species are there, in especially this the dry climate. And this is one of the African cobra. There are more than 10 species of cobras in Africa. And this is one species came to our hospital. We found this in our hospital ground and taken photos. Still, I don't know what is the species. And a lot of species not identified. It's poor country, no studies, nothing. And a lot of snakes are there. Patients come and a lot of patients dying, right? So you know this is a spitting cobra. So it's this cobra spit venom to the prey, and then the prey become temporarily blind. Then it catch the prey. So a lot of mechanisms are there, very interesting thing. And if you read this, a lot of African the snakes, very interesting topic, right? So just for my I put these photos. This is can you see? I think the photos. The largest wetland of the world, that is called Shud wetland. That is a part of Nile River. Our hospital located just beyond this beautiful area, and we always fly on helicopters of this area. Very beautiful, and you can see these photos, and you can see the community there. They are living, very poor people, and they are living there, and they are fishermen. Lot of hippos, Nile crocodiles, animal attack, everything is very common in this area. And but very beautiful. And see this photo, the third one, small houses are there, whole surrounding areas are savanna and animals, and they have to live with animals and snakes, right? So a lot of snake bites come to the hospital, not only the hospital, we get few patients, but a lot of patients go to their hospital, but they have no facilities of the management of snake bite there. So clinical evaluation of snake bite envenoming, this diagram shows the fang with this venom gland and the venom duct. When bite, the venom inject into our body, and I'm not going to discuss more detail about the chemical components. A lot of chemicals are there in the venom. And clinical manifestation, there should not be any single symptoms or signs, but can cause death also. Try bite to death. So I discussed both cases. Our schoolboy came without envenoming signs, and other lady died after 4 hours of the envenoming. So lot of clinical picture, different clinical picture, and clinical evaluation of snake bite patient. I think this audience need know this explanation, so you know how to assess the patient, A, B, C, D, E, and assess the patient and resuscitate the patient if needed, and stabilize the patient. Then look for specific signs of local envenomation, neurotoxicity and coagulopathy. You can see whether patient's limbs are swollen, blistering or tissue necrosis are there, and signs of neurotoxicity with ptosis, external ophthalmoplegia, limb and respiratory muscle paralysis. Then signs of coagulopathy, bleeding, sometimes 20 WBCT is prolonged. So those are the important things you have to look. And I just describe this slide. How do you do 20 minutes whole blood clotting test according to our guidelines here published, and you can advise your nurses to do this. This is very simple when you are doing periphery works, and very simple test, nothing special. And ask to get 5 milliliter glass test tube and put 1 milliliter of blood, and then keep this sample for 20 minutes without disturbing, without shaking. Keep 20 minutes. At the end of the 20 minutes, you take this sample and see whether clot is there or not. So if clot is there, already clotted blood and not envenoming patient. If clot is not there and blood is flowing, that means coagulopathy is there and patient is envenom. So that is how you can interpret, very simple. Don't ask nurses to shake in between, the clotted in 5 minutes, clotted in 10 minutes. We don't want to do it. We want to see at the end whether blood clot is there or not, right? Whether clotted in 10 minutes, not. If you shake it, it affects the clotting process, right? And these are the pictures from the internet. Then first picture of one of our patient, and you can see local effects, swelling, tenderness, then gangrene, and extensive damage to the limbs and fingers. I know that Africa, every day people lost their legs because of the snake bite. And you can see neurotoxic effects after cobra and cat bite, ptosis, ophthalmoplegia, even end up with the intubation and ventilation because of the muscle paralysis, bleeding, vascular toxins common with viper bites, and nephrotoxic, hematuria, anuria, or even oliguria. Then myotoxic effects, rhabdomyolysis, end up with the renal toxicity. And this is the summary of clinical manifestation. It's little important, the table. You can see rhesus viper venom contain and cause local effects, coagulopathy and neurotoxicity. All sort of venom toxic substances are there in rhesus viper. Cobra only local effects and neurotoxicity, there is no coagulopathy. Crate only neuropathy, neurotoxicity, no local effects at all. We have seen a lot of patients, even no bite marks, and coagulopathy also not there after crate bite. Saw scale viper, hump nose viper, green pit viper, their venom can cause local effects as well as coagulopathy and no neurotoxic effects. And sea snake can cause rhabdomyolysis and even after that renal involvement. And factors affecting severity of the envenoming. Children's overall worse than adults, their body weight is low, and the same dose of venom go into the body and can affect severely the bitten by children. Then bitten on the trunk, face, and directly venom injected into the bloodstream is very dangerous, and patient come with severe envenoming signs. Then exercise or exertion after snake bite is again dangerous situation, and they can come with severe toxicity or sort of envenoming signs. Secondary infections at the site of the bite can end up with sepsis and septic shock. Then volume of venom remaining in the gland is very important. I discussed dry venom or maybe severe envenoming. Then species is very important. That's why we should have some knowledge about identification of the species. So I think we already discussed. Then first aid. What is the first aid? So patient should be moved for the safety, and reassure the patient. Remove constricting clothing, rings, bracelets, bands, and shoes. Then transfer patient to medical unit where AVS available. And PCM for pain. A tight tourniquet should never be used. So approach to a patient, you have to first confirm whether snake bite or not. We have seen patient come with a thorn pick and say snake bite, but when we go back to the history, that could be thorn pick. So then is it like to be a snake bite? Then you examine the patient and see envenoming signs and symptoms, and then if snake, nowadays lot of patients bring a photographs, right? So we can examine the photographs and see what is the offending snake. Then specific treatment, this is very important. In Sri Lanka we have polyvalent antivenom imported from India, and this antivenom we use for cobra, rhesus viper, common crate, saw scale viper bite. Then greater vigilance and more frequent 20 WBCT are needed, and early detection, vigorous treatment of anaphylaxis is to be very important. You have seen this our case report, and severe anaphylaxis. So this is a management algorithm. You can see antivenom therapy if patient is envenomed, and systemic envenoming with systemic envenoming or local envenoming only with cobra bite, you have to use antivenom. Otherwise, you have to wait for the systemic envenoming to start antivenom therapy. And then antivenom administration, this is also important to know, pre-medication with low dose adrenaline is recommended now, right? If your patients come with systemic envenomation who needs antivenom, then you can give 0.25 milliliter of 1 in 10,000 adrenaline subcutaneously before starting antivenom. That may be helpful, right? So pre-medication with antihistamine and hydrocortisone is not recommended. This is not very effective way of treatment. Then this is the dose and the route of administration. 100 to 200 milliliter of antivenom, that means 10 to 20 ampules of antivenom or more of Indian polyspecific antivenom in 400 milliliter of normal saline, infused intravenously over 1 hour. That is the method we use in first hour. And in cobra and Snakebite, usually 1 antivenom dose, that means 10 ampules are enough. And in rhesus viper bites, the first antivenom dose could be 20-30 ampules, and you have to repeat if required, if needed, right? So anaphylactic reaction management, non-pharmacological measures, temporarily stop the antivenom infusion, airway management and fluid resuscitation. Then pharmacological management, the drug of choice is adrenaline, nothing else. So if your patient develop anaphylaxis reaction, you have to give adrenaline intramuscular, right? So IM is more efficient than subcutaneous injection. That is proven with the data. And if bronchospasm and other symptoms are present, you can use salbutamol nebulization, IV Piriton, so on. And intravenous hydrocortisone can be given, but it is likely to act after several times. You have seen with our case, so it is not effective way of treatment for the anaphylaxis. The drug is adrenaline. Don't wait, give adrenaline if your patient is having anaphylaxis, right? So other supportive treatment, tetanus toxoid, fluid management, transfusion. So FFP and blood may need transfusion, especially green pit viper and hump nose viper bite. We don't have specific antivenom. So if they are available blood after green pit and hump nose viper bite. Antibiotic, and surgical care and ICU care needed. Prevention of snake bite in house. Do not keep livestock, especially chicken, in the house because snakes come into the house. Store food in rat-proof containers. Raise beds above floor level and use an mosquito nets completely tucked under the sleep mat. The reason, especially villages, they are sleeping, then they go to the isolated places, and if they sleep on the ground, crate come and bite. So you can stop, prevent this one living. We can advise to sleep on the bed, and also if it's a dangerous place, to use mosquito nets, then they can't come onto the bed. Then in the farmland and the garden, use a light and wear shoes, very useful, and just to prevent the snake bite. And clear heaps of rubbish building materials from the house. Do not have tree branches touching the houses because snakes come into the houses. Keep grass short and ground clear. Listen to wild animals and domestic animals. What is the reason. You have also seen sometimes the different calls coming from the different species of birds if they have seen snakes in the environment. So we can listen for that sounds, and you can understand there may be snakes. And keep your granity away from the houses. And in the bush and country sides, watch where you are working. Watch where you are walking. Do not put hands into nest or any hiding places. Wild animals, especially birds, may warn the snake nearby. Be careful when handling dead or apparently dead snakes, right? So many snake bites occur during planting, harvesting, and in the rainy season. So actually this is a very important facts to pass for the general population, especially here Mahiyanganaya. They have to take many precautions to prevent snake bite. So drivers or cyclists should never intentionally run over the snake on the road, can get bite. And snake bite, do and do not. Don't do these things. Do not send patient for the traditional medicine. Do not suck the wound. Do not cut the wound and open. Do not tie around the wound. Do not burn. Do not apply any herbal paste on the site of the snake bite. So what you want to do, immobilize the affected limb. That is most important thing. And do rush the patients to the nearest hospital that can deliver anti-snake venom and emergency care. So that is what we want to do and advise for the patients. And thank you for you all for the listening. And also what we want to do is conserve snake while we save. Right, I think I finished. It take 1 hour, a little bit more than 1 hour. And if you have any questions, I can try to answer. Yes. Yeah. Yeah, I can hear you. Sorry, it's not. Can you repeat it? Sorry. So So also if you are happy, you can, there is a question Q&A small session, and there is a link, and you also can go to your the GMOA group, and you can go into this link and get the question, simple questions you can answer, and then submit quickly within 15 minutes. Then we have a small gift for the winners also. If you are willing, you can go and just answer for those questions. Link is there, right? Then we'll see. If any questions are there, you can ask, I will answer. I will quickly discuss the question and answers. This is the first question. What is the snake, right? What is this snake? We have given 4 answers: common krait, Sri Lankan krait, Sri Lankan wood snake, and cat snake. So this is this is Sri Lankan wood snake, right? Not the Sri Lankan krait, because vertebrals are not enlarged, and this is similar to Sri Lankan wood snake. The answer is Sri Lankan wood snake, right? So this is the second question. The adult pre-medication dose of adrenaline before AVS is 1 in 10,000, 1 in 1000. What is the dose? The answer is 0.25. We should know it, right? This is the third question. The usual dose of AVS for krait envenoming is 5, 10, 15, 20, 25 hours. The dose is 10 vials. Right, what is this snake? And we discussed this case, and it's a very common snake bite reported in Mahiyanganaya area. This is, what is the snake? That is trinket snake, right? So katakalua, and answer is trinket snake. And this is, what is this snake? And I discussed, this is the newly considered as venomous snake. So this snake, you can see the reddish brown head with characteristic appearance. The snake is Sri Lankan keelback, now considered as a venomous snake. And according to the new classification, what is the snake is not included in category 1 group. You know, 4 snakes included in category 1. The last one, Bangaras silanicus or Sri Lankan krait, not included in category 1, included in category 2, because we have limited data. But it is a venomous snake. Epidemiological data is limited and included in category 2. Then a 25-year-old gentleman presented with a snake bite, and he developed swelling and severe pain over the bite site. He has bilateral ptosis, ophthalmoplegia. 20 WBCT was less than 20 minutes. What is the most likely offending snake? So there is local toxicity and neurotoxicity only, and there is no vascular toxicity. So snake is cobra, right? So this is the answer is the cobra. AVS indicated for only local envenoming without systemic envenoming is, what is that? Answer is krait bite, right? Sorry, what is that? AVS indicated for only local envenoming without systemic envenoming is cobra bite, right? So this is for the local bite without systemic envenomation. The answer is cobra. You know, I discussed it. And what is this snake? Bird's foot mark is there. So this is scale viper, right? So the last question: extensive limb swelling is not a feature of envenoming with. Answer is local envenomation is not there. Answer is Sri Lankan krait, right? So those are the answers. Thank you very much for joining with us, also giving your valuable time and answering for the questions. Thank you.